All right, so it's 5 o'clock. I think we'll get started, if that's okay with you, Dr. Herzig.
I'm good, ready to go.
All right, so welcome everybody. We'll probably have a few more people trickling in as the 5 o'clock to 5:05 time period rolls around. But I'm very pleased to have Dr. Herzig join us today. Dr. Herzig is a refractive surgeon at the Herzig Eye Institute in Toronto. Has been there for 2.5 decades doing refractive surgery, and is a very kind of well-known name in the Toronto area and the Canadian, on the Canadian scene for refractive surgery. And so we're going to be talking about SMILE today, and Dr. Herzig has started very early doing SMILE when it was first approved in Canada, and so he's going to be sharing his experiences on the SMILE procedure and what we should look for before surgery, during surgery, and after surgery, and some really practical tips. This session is being recorded, so we'll be able to view it later. But I will ask for anybody on the call right now to mute their computers and mics so that we don't have any feedback or extra noises. So thank you everybody for joining. Thanks for muting. And Dr. Herzig, it's all yours.
Thanks, Kashif. Thanks for inviting me to speak about SMILE. I don't know if I should be thanking you. You ruined my weekend. Anyway, as Kashif indicated, I started when it was first approved in Canada, and it's been a little over 4 years. I've done somewhere around 4,000 procedures. So I hope I can impart some useful knowledge to all of you, whether you're already doing it, maybe you can pick up a pointer or two. If you're thinking about getting involved in SMILE, you'll have a sense of what's involved preoperatively, postoperatively, and intraoperatively.
And Dr. Herzig, we have people who are like techs, residents, optometrists on the call. So along the way, if you have any pearls or any comments that would be useful for them, it'd be great to hear that as well.
Sure, I think a lot of these things, certainly for the optometrists, it's good to know how to speak to their potential refractive patients about SMILE, so this will come in handy. And for residents, it's nice to know what's out there, and when they do get out, it helps them make a decision about becoming refractive surgeons or not. So I think the information, as you indicated, Kashif, it's going to be more practical, more of a practical presentation, a little bit of science thrown in, but mainly my experience in the issues, both pre-op, intra-op, and post-op. So I hope it gives good information to everybody who's listening. So what I'm going to do now is start the share. Okay, so is that working okay? You can see my first slide there, which is just a title slide. I assume since nobody said
all
no.
Good, all good.
All right. Okay, so let's look at first off, and this is certainly. Oh. There we go. I got to keep my hand off the mouse here. So preoperative considerations. Well, when I first started out educating patients about SMILE relative to LASIK and PRK was a little difficult. It was very important, and I still feel it's really important to make sure we don't downplay LASIK and PRK. There's a place in refractive surgery for all three of these laser procedures, as there is for other refractive procedures, ICLs and refractive lens exchange. When I did first start out, unfortunately, one of my colleagues in the city was upset that I'd started SMILE and distributed some less than accurate information to referral sources and patients. And that just created confusion. And in the end, the fact that SMILE is a good procedure, gives good results, it speaks for itself. And when I'm talking to patients now, I present all three laser procedures and discuss the differences between them, the pros and cons of each procedure, and let people know that these are all excellent procedures with good results. The important thing is choosing the right procedure for the right patient. Once a patient decides to proceed, we of course have to go through all the usual diagnostics, always making sure that we don't have a patient that's susceptible to ectasia, and all the other information that we get from our diagnostics is of course important. But the ectasia risk is one thing we want to be sure we eliminate. And there's been a lot of discussion in our peer-reviewed studies about corneal biomechanics and dry eye. What has been shown is that the anterior corneal stroma is stronger than the posterior, significantly stronger. Randleman did studies on this in testing the tensile strength in donor corneas. And the issue of LASIK versus SMILE, which one weakens the cornea more, I don't think there's any doubt that the LASIK flap significantly weakens the cornea and doesn't contribute much. The flap itself doesn't contribute significantly to corneal biomechanics once it's made. And Marshall actually showed that even without making a flap in donor corneas, just making the side cut weakened the cornea as much as making the flap. So not doing a side cut certainly maintains corneal strength. So the thinking is, and there's enough evidence that the SMILE cap continues to contribute to the corneal strength. And that allows us to do SMILE in a lot of patients that we normally would have done PRK in the past. The dry eye considerations, probably the main reason why patients are actually coming in asking for SMILE. There's been a lot of negative publicity about LASIK and PRK in the past and creating chronic dry eye issues and in some instances permanent dry eye. So if a surgeon is doing both LASIK and SMILE, there's a certain group of patients where one would tend to lean more towards SMILE. Patients that are starting out with dry eye symptoms, already using some drops, artificial tears. If they have meibomian gland dysfunction, you do want to clear that up, but they still are more susceptible to dry eye. Contact lens intolerant patients obviously don't have the best of tear films if they can't tolerate their contacts. There's no doubt in my mind that over the years, the most likely group of patients, well, there's two likely groups of patients that end up with chronic dry eye are Asian patients. That's, I believe, one of the reasons why in the Far East, SMILE has become so popular. And there's no doubt that older patients, menopausal women, and even men, because our meibomian glands tend to wither, they atrophy with age, and certainly the tear film is not as stable as we get older. So these are patients where one would think about doing SMILE rather than LASIK. This was an interesting meta-analysis done by Reinstein and published a couple of years ago. And the blue graph was a meta-analysis of 7 studies that showed how much loss of sensation there was after SMILE. And you can see, comparing the blue line to the red line, that the loss of sensation with SMILE in general was less, and the recovery was faster. And with corneal nerves returning to normal faster, you would expect less dry eye and a more rapid recovery of the dry eye symptoms. So in planning smile surgery, there's a lot of considerations. Just like with LASIK, most surgeons don't want to go below a residual stromal thickness of 300 microns. We make the same calculations with SMILE, but most SMILE surgeons are more comfortable going a little thinner in the subcap residual stromal thickness. And it varies. I've talked to various SMILE surgeons. Some are very happy to go right down to 250 microns under the cap. And that's the lowest you can go. The laser won't let you go below that. But there are some who are more conservative and won't go below 280 microns. I'm somewhere in the middle. I like to obviously maintain as much stromal thickness as I can in making my calculations as to whether to proceed with SMILE or not. But one aspect of SMILE that most SMILE surgeons believe, and I think has been shown in studies, is that the total residual stromal thickness includes the subepithelial stroma on the cap. So if you think, and I'll show you an example of that in a moment, but if you're thinking about a cap that's 120 microns, 50 microns of that is approximately 50 microns is epithelium, and underneath you've got 70 microns of stroma that we believe contributes to the residual stromal thickness. And that's why we can do SMILE in thinner corneas. So it definitely is a better option than PRK in thin corneas, simply because of the faster recovery. And this is what's bringing a lot of patients in. They've been told they have to have PRK at other centers that don't do SMILE. And there's patients who just won't do PRK. They'd rather wear their glasses. They've gone online and heard horror stories about pain, which is really not that relevant, but that's what they believe, and they jump at the option of having SMILE rather than PRK. So in planning the SMILE procedure, you can vary the thickness of the cap. In thinner corneas, I'll go down to 110 micron cap, but if a cornea can take a little more tissue, thicker corneas, I like to use 130 micron cap, mainly because if I have to do an enhancement and the patient is a good LASIK candidate, and we'll talk about enhancements in a moment, I like to do a thin flap LASIK, and having 130 micron cap allows you to do a thin flap LASIK enhancement, and there's still enough stroma within the cap before going into the interface. As far as lenticule diameter, that's of course variable as well, just as the size of an optical zone is variable in LASIK. The range that I use is 6 to 7 millimeters. Very rarely do I go to 6. If a patient has very small pupil, very thin cornea, obviously the smaller the diameter of the lenticule, the less tissue you're taking away. Most of my SMILE procedures are done with a 6.5 millimeter lenticule, 7 millimeters for larger pupils, and for very thin lenticules, doing very small myopic corrections, diopter or so, it's nice to make the lenticule a little larger diameter, because you obviously get a thicker lenticule that way. And speaking of thicker, you always have to add a non-refractive lenticule add. So it's sort of the base of the lenticule. There's no refractive correction involved in it. The minimum lenticule add is 10 microns. And the reason for that is you have to have some edge thickness. And if you had a lenticule that had virtually, as you know, as you get further out from the center, the lenticule gets thinner. You have to have some substance to the edge of the lenticule to be able to dissect it comfortably and avoid tearing it. So the minimum is 10 microns. The laser won't let you go below that. And again, with small refractive errors, you can go up to 20, 25 microns of this non-refractive lenticule add that allows you to have a more substantial lenticule. and reduce the risk of tearing. The other variables that you can use in your treatment are the laser energy settings. I use routinely 110 nanojoules. I've ranged from 100 to 140. 100, when you go down to about 100, you might not get an effect. So I haven't done that in a while. Been advised by Zeiss not to, but I think there are some surgeons going down to 100 if your laser can do it. Because as you'll see, I mention it in a moment, the less energy you use, the faster is your visual recovery. So it's nice to use the minimum laser energy that will get you a nice lenticule dissection. Similarly, spot and space size is important. The smaller the spot size, the more energy you're delivering to the cornea. So you want to have a spot size that makes it still easy enough to do your lenticule dissection. And the larger spot size will, you'll also have bigger spaces between the spots, so the lenticule extraction can be a little more difficult. So it's a balance of laser energy setting, spot and space size that you have to find. Every laser is different, and once you get the right settings, the lenticule dissection should be very smooth and easy. Nomogram development, as it is with LASIK, really critical. The Visumax laser for SMILE tends to undercorrect, and you have to always add a little bit of correction. And this is something, if you're just starting out in SMILE, I think it's good to get someone else's nomogram, and as I did, and go from there, make adjustments as your results come in. Here's an example of a difference between a SMILE procedure and a LASIK procedure. An example, this is a 5 diopter treatment in a relatively thin cornea, 500 microns, using a 6.5 millimeter optical zone for each procedure. So with SMILE, assuming the surgeon used a 120 micron cap, we look at that as 70 microns of stroma, and obviously this is approximate, but on average, it would be about 70 microns of stroma and 50 microns of epithelium. And typically, surgeons use 100 micron flaps with LASIK. The difference in tissue removal is subtly different, but it's going to be approximately 90 microns with each procedure. So on the SMILE side, you take off the 210 from the 500. You've got a residual stromal thickness under the cap of 290 microns, but you still have some cap stroma that is going to contribute to the strength of the cornea. So the overall residual stromal thickness is equivalent to about 360 microns. On the LASIK side, it's obviously less because the flap doesn't contribute at all. So measuring this difference in vivo in humans, there really isn't a test available that can pick up the subtlety between 360 microns of RST and 310. There's the Corvus that we use, and the ocular response analyzer, the Aura, but neither of these tests are fine-tuned enough to pick up the difference. So when I've looked at studies that try to see if there's a difference using those biomechanical measurement instruments, there really hasn't shown much difference. But in vitro, looking at donor corneas, the tensile strength between the two procedures has been evident. Now, intraoperative considerations. It's not a difficult procedure. It does take, obviously there's a new learning curve when you start. There's different aspects to the procedure that have to be learned, and the first one is obviously docking the contact glass on the patient's eye. So patient communication, both before the surgeon starts and during the procedure, are really important because there is a target green light that the patient has to look at, and I actually have a procedure video to show. They look at this target green light to get them started, and about halfway through the laser treatment, they can't see it anymore. So as long as the patient understands that, they understand that their eye is going to be held in place with a little bit of light suction because it's so important for their eye to be centered with the laser. And they have to know that if they move forcibly, they can break that suction in the middle of the procedure, and that's not a good thing. So they really need to know that beforehand that they'll lose the fixation light, not to go looking for it, and that I, as the surgeon, will be warning them just before that happens, and to remember to just stay exactly where they are, to actually imagine the fixation light is still there exactly where it was before. So what happens if there is a suction loss? Well, if it happens while the posterior cut of the lenticule is being made, which is the first part of the laser treatment, you can't continue anymore. You have to abort the procedure and convert either to LASIK or PRK. Once that lenticule cut is made, you can reapply the contact glass and complete the procedure with minor adjustments. So if, let's say, the side cut hasn't been made yet, you just have to reduce the size, the diameter of the lenticule, so you make sure you're within the lenticule when you reapply the suction. But there's a step, the laser actually tells you what to do. So the main thing is not to panic, to reapply the contact glass and make some minor adjustments, and it's very easy to complete the procedure. One issue that comes up occasionally, I've been fortunate to never see this to any large extent, is what are known as black areas. And these are areas where the laser just hasn't penetrated, presumably because there's some sort of debris, maybe mucus on the cornea that's blocking the laser. And there's an area that, if it's large enough, you may not be able to dissect through it. So if it's really covering a large area, you have to consider converting to a different procedure depending on the size of that area. I think you can prevent this from happening just by wiping the cornea before starting with a moist microbe sponge to make sure that there is no significant debris on the cornea. Very common thing that happens is a little abrasion around the wound. And it's certainly more common in presbyopic patients. The superior corneal epithelium is definitely looser in presbyopic eyes. So when I'm starting and I see that the epithelium is a little loose, rather than continuing, I just sweep the epithelium, the loose epithelium, away from the wound, both on the cap and posterior to the cap, above the cap, so that I'm not ripping the epithelium. When the procedure is over, I can just slide the epithelium back in place. Some surgeons just take it off, and that's fine too, but then you have to put a contact lens on the patient, and that delays visual recovery a little bit. So if you do get a tear, you really have to account for that lost epithelium. Is it on the instrument? Is it in the interface? You've got to make sure that you find it. You may not always find it, but it's very difficult to see the stromal interface with the microscope, even though it has a slit beam on it. It's a little easier with retroillumination, but if you lose some epithelium, you certainly have to take the patient to the slit lamp after the procedure and make a careful examination of the interface to make sure that no epithelium has been left behind. And it's happened to me a couple of times where I saw it on slit lamp post-operatively, and I had to take the patient back and to clean it out. And there are some nice instruments that make it easy to scoop those little bits of epithelium out of the interface. On 2 occasions, I've had patients that I missed it completely, and I had to go back weeks later to get some epithelium that was interfering with sight. Wound tears occasionally occur. There's a little extension of I use a 2.5 millimeter wound, Some surgeons use 2, some 3. I believe that in the U.S., and I don't know if they still have to, they have to have a 90-degree wound, so that's pretty big. But we can do whatever size we want. And when the lenticule dissection is occasionally difficult and it's a little more of a struggle, it's not unusual to get a little extension of the wound, but that's of no consequence visually. One thing that does happen, even after doing 4,000 procedures, it still happens to me occasionally, is instead of going into the anterior surface of the lenticule first, which makes the dissection much easier, end up dissecting in the posterior side of the lenticule first. And the best way to prevent that from happening is by keeping the entry tip, the 90-degree tip that we use, looks like a Sinskey hook, keep it pointing up and scraping it underneath the cap to make sure that you're in the interface above the lenticule. If you happen to dissect the posterior lenticule first, when you finish that part of the dissection, you go looking for the posterior side and you can't find it, and you realize that you got to go anterior now. So again, you use that entry tip to find that anterior surface. And at this point, because the posterior side has already been dissected, the whole lenticule is a little looser. So it's a little more difficult. So it's not the end of the world, but it just makes the procedure a touch more difficult. The posterior, when you've got it right and you've dissected the anterior surface and now you're working on the posterior side, it's really important to maintain 2 lenticule fixation points. Because if you completely dissect to one side, you're going to end up with a taco situation where the lenticule folds on itself, and that makes it much more difficult to get it out. So I like to leave on one side a nice area where the lenticule has not been completed, and go over to the other side, and just near the entry wound, leave another point of fixation. And then I can go back to the bigger fixation point and loosen it, and then very easily get the lenticule out. Once it's out, especially when you're first starting to do SMILE, it's really important to put the lenticule on the cornea, moisten it, spread it out, and make sure that you got it all, because you don't want to leave a significant portion of the lenticule in the interface. Okay, this is a video of one I did quite a while ago. I've changed my technique a little bit, but this is pretty much what I still do. Thought you might want to see a procedure. So there's the fixation light that I mentioned, and you can see the contact glass coming closer. At this point, it's a little foggy for the patient, but as soon as the meniscus starts, they can clearly see that, and they fixate on that. The suction starts, and once the suction gets going, the posterior cut is made of the lenticule, and it's just about this point where you warn the patient that the green light will be hard to see, and then the anterior cut starts after the side cut. And this takes about 30 seconds. And you can just see the entry wound down below that's not totally visible. I like to use a 0.12 forceps to hold the eye. Some surgeons don't use any fixation forceps. And there's the Sinskey type tip that is used to get on the anterior side, and then a little separation of the posterior side of the lenticule. And I like to use a sweeping motion, starting from one side. I found that this is the most efficient way of separating the anterior side. You can't do this on the posterior side because you have to maintain those 2 fixation points. And now the posterior dissection of the lenticule. And here you have to go down the center and go to the right. And you can see that on the right side, I've left a little section. And then just near the wound, I've left an area. And then finishing up by completing those two. And usually the spatula, you can just pull out the lenticule with it. I don't like going in with a second instrument unless I have to. And there is just the spreading of the lenticule to make sure it's all there. So, as with any procedure, there are post-op issues. A lot of them are minor and have no visual significance. There are several interface issues. You can get the odd speck of debris just like you can under a LASIK flap. And it's almost never that you have to go in unless there's some reaction around it. Epithelium, as I mentioned, is something you want to avoid in the interface. And certainly if it's there later on, you've got to go in and get it. Interestingly, I have never seen a diffuse DLK in a SMILE patient. I sometimes see a few cells near the wound, especially in patients that have vascularized corneas. So hasn't been a significant issue with SMILE. If a lenticule remnant is left behind, and if it's a significant remnant, it's going to create irregular astigmatism, and you definitely have to go in and get it. I have never had that happen to me, fortunately, but I've certainly seen not other patients, but presentations of surgeons having to deal with lenticule remnants. And there was one situation where it was so difficult to get the lenticule out, the surgeon had to convert the cap into a flap to get the lenticule remnant out. So it's not something that you want to have happen. It's not unusual to see a little bit of haze in some of these patients, but I've never seen it be visually significant. Night glare. This is an interesting issue with SMILE patients. Definitely in the first 2 to 4 weeks, SMILE patients will complain more of haloing or glare at night, and that's because there's a little stromal edema. But once that goes away, and it can take anywhere from 1 to 4 weeks to go away completely, their vision improves and the night haloing improves as well. Ectasia certainly has been reported with SMILE. I've had one case of ectasia, which led me to get involved in Corvus testing of patients, which I'm going to talk about in a moment. Infection is always something we mention to patients as a possibility, and certainly very rare. And corneal neuralgia, which I'd also like to touch on, is something relatively new that we are recognizing as a significant entity. And residual refractive error, something, of course, that's going to occur in some of our patients that we have to deal with. So as I mentioned, I had one case of ectasia, unexpected, despite our pre-op testing. I don't know why, but we decided to invest in the Corvus system to see if we could pick up weak corneas that don't seem to be weak with our usual testing. The Corvus works by recording the reaction of the cornea to a defined air pulse. It gives two values. One is called the Corvus Biomechanical Index, or CBI, and that involves 5 or 6 actual deformation tests of the cornea. And the tomographic biomechanical index, which takes into account the CBI and adds that information to the pentacam information to give us the tomographic biomechanical index. And the basic concept is for detection of clinical and subclinical keratoconus. It's based on the biomechanical response of the cornea, combination of 6 parameters. It takes into account the pressure and corneal thickness, and it gives a range of measurement between 0 and 1, with 0 being a perfectly normal cornea and 1 being a dangerous cornea. And this is one of the screening parameters, which is the ratio of the deformation of the cornea within that 2 millimeter area from 1 millimeter to 2 millimeters. And the radius of curvature, they call the integrated radius, is another screening parameter. And this is what the Corvus assessment looks like. If you look at the bottom, this is the CBI. This is a normal cornea. This bar here, if it was abnormal, that little black line would be either in the orange or red. Red would mean that it's a very high suspicion of being formed frusk keratoconus and that the cornea is weak. And this information is combined with the pentacam information in the top right to let us know that the tomographic biomechanical index is excellent here. So this is a very good cornea to do any laser procedure on. Just a thought about corneal neuralgia, because I've had one patient with it. It's more recently recognized as a significant but rare complication of any of the laser procedures. The symptoms do overlap with dry eye, but there's more general ocular and head pain. It doesn't respond to usual dry eye treatment and tends to persist. Some patients do complain that they can't function. It's that bad. It's apparently due to aberrant regeneration of corneal nerves, as was shown by, I forget his name now, it's an ophthalmologist in Tufts in Boston. And he's been treating patients, as I have my patient, with serum tears, and there is definitely some response, as well as the usual oral meds that are used for neuralgia, like gabapentin, and there's other ones as well that are more significant. And I think when this first started, we were looking at patients that were 20/20 with perfectly normal looking corneas that didn't even look dry. But these patient symptoms shouldn't be dismissed. There's something going on with the corneal nerves that I don't know if we totally understand. So what do you do if you have some residual refractive error? As I mentioned earlier, if it was a patient that was a good candidate for LASIK as well as SMILE, and I was able to do 130 micron cap, my favorite enhancement procedure is a thin flap LASIK. Use a 90 or 95 micron flap and just do a LASIK procedure. These patients do very well. PRK in patients who are not candidates for LASIK to start. There's not enough corneal tissue and the cap is a little less thick. And there is a software option called the Circle option on the laser, which allows you to convert the SMILE cap to a LASIK flap. But I've never done this. I think it's a little more aggressive and certainly weakens the cornea more than doing a thin flap LASIK, but I know there are some surgeons who are using it. So to summarize, I think SMILE is a wonderful procedure. It provides excellent visual results. It is a little more complex surgical procedure, but very easy to learn. The nomogram development is really important if you want to have long-term good visual results. And on the short term, get more patients who are 20/20 on day one with lower laser energy levels used. It definitely has reduced my need for PRK. I almost never do PRKs now. And I really believe that using the Corvus ST to assess ectasia risk adds another level of safety to any of the laser procedures. So thank you all for listening. I'm going to stop the share and happy to get involved in a Q&A.
All right, any questions from the audience? Okay, while you guys are thinking of questions, I do have one question. What is your preferred way of doing post-cataract surgery correction of refractive error? Does that include SMILE?
Well, usually it's rare to have a very significant residual refractive error. And I certainly wouldn't, I have used SMILE on a couple of occasions, but More typically, I'll do PRK with occasional LASIK. Again, you're into dry eye issues with these patients, and you want to do less LASIK usually, but at the same time, you want them to recover faster. So I do LASIK. I have done some SMILE, but keep in mind that you can't do hyperopia yet with SMILE, and the minimum myopic correction that you can do with SMILE is half a diopter. But I certainly wouldn't do a SMILE for just a half a diopter. Whenever I've had a spherical error of a half diopter that I've done with SMILE, it's been with a significant myopic astigmatic correction along with it.
Okay. And so you mentioned hyperopia you can't do. What is the range? I guess it's people from different countries in the audience, but in Canada, what is the range that you're treating for myopia and cylinder?
Yeah, well, in Canada, we're officially only approved up to 2.5 diopters of astigmatism. I think most of the SMILE surgeons in Canada will cheat a little bit, but not much. But you can go up to 6 diopters of cylinder with SMILE. And you can't go higher than 10 diopters of myopia. I like to do ICLs when I get into patients in the very high levels of myopia. It's my favorite procedure for anything over 9 diopters for sure, and obviously we can't use it for over 10. So that's the limit, 10 diopters with 6 diopters of SIL, but in Canada, 2.5 is the approved limit.
Okay. And when you do your after SMILE, if you're doing a refractive touch-up, the LASIK that you do, you're using the femto laser to do your thin flap LASIK. Are there any issues with the gases tracking through previous wounds or anything like that?
Hasn't happened. It maybe could, but I haven't had any issues doing a thin flap LASIK over SMILE. It's been a very nice procedure. You have to, when you're lifting the flap, you just have to do a little more gentle dissection where the SMILE wound was, but it's usually not difficult.
And in your cases where you've done your SMILE procedures, have any of those patients come back for either refractive lens exchange or cataract surgery a few years later? And how would you treat the IOL calculations post-SMILE? Because we have, post-LVC for PRK, RK, and LASIK. Is there anything different for SMILE?
No, I think it's exactly the same. It's just a matter of having changed the curvature of the cornea. It doesn't matter whether it's PRK, LASIK, or SMILE. I've done one patient who came back a couple of years later with a cataract after SMILE. Just treated the same way as LASIK, post-LASIK. Okay.
And when patients come in and they've heard about LASIK, what has been their reaction to SMILE when you first talked about it? Because I guess it's being a bit more well known now, but when you first started off, you mentioned there's quite a bit of education that was needed.
Yeah, well, you're right. First of all, now people are coming because they want SMILE. It's been out there long enough. The social media, the internet, almost nobody comes in not having researched everything. And the other thing we're doing now, was initiated due to COVID, is we do the virtual consultation. So all these things are pre-discussed with patients as a possible option. So it makes it a little easier for me or the optometrist who is seeing our consults for the first time. And the main, I don't get into corneal biomechanics with the patient unless there's a good reason to. I think the main issue that I discussed, I always tell them that I love all these procedures, and the main reason why we do more SMILE than LASIK is simply because we feel there's less less dry eye, chronic dry eye potential. But some patients have had their friends, relatives done with LASIK, and everybody's happy and they want the same thing. So as long as they're a LASIK candidate, we certainly do it.
So what is your kind of mix of patients that are getting SMILE versus LASIK versus PRK now? I
can't remember. The PRK I basically use for enhancements. It's been a while since I did a primary PRK. So I would say it's about 90% SMILE now and 10% LASIK.
Mm. Okay. So then how, when your optometrists in your community are talking to patients that are being sent over, are they fairly well versed, or what pearls would you have for the optometrists in the audience in terms of what they should tell patients or what you would suggest they tell patients?
Yeah, I think to keep it simple, I think just dealing with the dry eye issue, especially, optometrists are usually quite familiar with their patients. They're dealing with a lot of contact lens intolerant patients, and they just have to educate them that the potential for long-term dry eye is less with SMILE than it is with LASIK. Not that LASIK patients get permanent or real chronic dry eye to a large extent, but there were enough patients like that over my 25 years of doing LASIK that stimulated me to want to find another solution. And I think to keep it simple with just that one issue for optometrists will help patients understand that there is that one benefit for SMILE, but again, to stress that LASIK is still an excellent procedure because we're still doing it, and we don't want to put ourselves down.
What is your drop regimen afterwards? Like you mentioned with the halos at some of the in the first 2 to 4 weeks post-op, so do you continue steroids longer than usual, or what do you do for drops after SMILE?
Exactly the same. It's a week of Ligamox and a steroid. I don't think using steroid longer makes a difference. The way you can see the edema in the cornea is with retroillumination. It has sort of a pebbled appearance, and you can see that diminishing over the first few weeks. And while it's still there, some patients will complain of a faint fog or a little bit of glare. But every SMILE patient is functional on day one. They can drive, they can go to work, they can do whatever they want. It's just they will more often than with a LASIK patient mention that little bit of haze in the first few days.
So what are the situations where you would prefer LASIK over SMILE then? And what scenarios would you do that?
That's a good question. I'm not sure that ever happens. The only reason I do LASIK is because somebody wants it. To be honest with you, I enjoy doing SMILE. Just as a surgeon, I enjoy doing that procedure more than I do a LASIK procedure. It's a little faster than LASIK. That's not the reason to do it, but just technically, I like doing it better. So if the patient doesn't care, I'll do SMILE.
And what are some of the new developments that you've heard from Zeiss and Visimax in terms of things that are coming up that would improve or make the procedure a little bit better?
There hasn't been anything recently.
Do we have a timeline for the hyperopia component?
Well, I know they've been doing some studies in Nepal. They've done some patients. I haven't seen any papers or talked to anybody about the results. The main issue with the hyperopia is how thin the lenticule is in the center, because with any hyperopic treatment, there's so very little tissue removed from the middle. So they must have to use a considerable non-refractive add to the lenticule to avoid a tearing in the middle. And I'm sure that's what they're doing. The main improvements for any surgeon starting out in SMILE is to find the best energy level and spot size that maintains, makes it easy to do their dissection, and actually does the dissection, because you can go to an energy level that's too low and nothing happens.
How long did it take you, or how many cases did it take before you came to a kind of comfort level with the energy settings?
Well, for some reason, when Zeiss is training, they start you off with a bigger spot size and a higher energy level. And at the beginning, the results were good. I had, a lot of patients were sort of 20/40 on day one instead of 20/20. And there were some difficult dissections. And so I spoke to more experienced SMILE surgeons and asked them what their settings were. And within a couple of months, I was adjusting things, going down to smaller spot sizes and lower energy levels until I found the best spot, best settings.
Okay. We have another question from the audience. So, in cases where we have kind of irregular corneas, and we often do, say, a PRK treatment, sometimes in combination with, let's say, cross-linking for ectatic corneas, how do you find, safety-wise, or what has your experience been in irregular corneas doing SMILE versus PRK?
Well, that's where the Corvus comes in. And when you're talking about irregular, we're not talking about irregular astigmatism, because that's something for sure you're not going to touch the cornea. But if you're talking about where the inferior cornea is steeper than the superior, depending how much, once you get much beyond a diopter of difference, I think the Corvus helps me decide whether I can do a laser procedure or not. And if it's showing that the cornea is a nice strong cornea, despite that the inferior cornea being a little steeper. And one thing we're getting into more now too is looking at epithelial thickness. And if the epithelium is not thinner over that steep area, then I'm comfortable doing SMILE or PRK. And my sense is that if we can preserve the anterior 25% of the cornea, that it makes more sense to do SMILE than PRK. And that's why I'm doing more SMILEs and not very little PRK.
Okay. So I guess in addition to the question there is, I guess topo guided PRK still has its place for these kind of weird corneas, but where the Corvus helps you in decision making, you still would go with SMILE.
Yeah, well, there's a difference between a weird cornea and a little bit of steepening down below.
Sure. Yeah.
With weird corneas, I don't care what the Corvus tells me. I'm depending on the age of the patient, how stable they've been. You either go right to cross-linking if you're concerned that there is keratoconus here, or if it is formed first keratoconus and it's been stable for long enough, or keratoconus, the ICL, toric ICL is a wonderful way to correct these patients and just stay away from touching the cornea at all.
Okay. All right, I guess in the last few minutes, any other questions from the audience?
No.
Anuj, Dr. Bargala, go ahead.
Do you ever see epithelial ingrowth with these patients? Or have you, and what's the incidence?
No, I've never seen epithelial ingrowth, but I've on 2 occasions seen, I didn't recognize that there was some seeding of epithelium in the interface. So it wasn't ingrowth. There was actually a couple little patches of epithelium in the interface that I had to go get.
Okay, cool. All right. Well, I don't see any other questions popping up here, Shelley. So with that, thank you so much for speaking to us and sharing your experience about SMILE. It's been very informative. I think we have been recording this, so this recording will be available later on for people to view. But I just want to say thanks for your time. I know it was, I have one more, maybe one last question here. Just double check. Oh, so just people saying thank you. All right. Well, thanks so much, Shelley. Have a great evening, and appreciate your time. And thank you.
And thanks for inviting me. Always a pleasure.
Have a great evening. Good night. Bye-bye.
Good turnout.
60 people.
Yeah, good.